I'm not going to stand here for an hour and give you 2 lectures. So I want to make this very interactive. I want you to join in, and I want to have a big brainstorming session about where we go forwards, because I'm not standing here knowing all the answers. So while I give you a bit of an overview about what we're going to talk about, please do have a think about anything that you can think that might change or transform the way that we look after people in our communities around dying and end of life, whatever that might mean to them. Doesn't matter how bold or wacky or different, or even if you think, actually, it's quite similar to the work we do today. I'm not sure it is that different. Please do have a think, bear it in mind, and we will start exploring some of that in a few minutes. But I just want to take you back a little bit to November, when I was planning my conference speech. And at that point, I'd been at Hospice UK for 3 years, and every single conference I'd sat down to think about what I was going to say, and I'd looked at the stats, and I thought, what an amazing job we're all doing. This is absolutely incredible. When I started in the job, we didn't even have the stats for the hospice movement. We didn't know what we were doing. We didn't know how many people we were helping. And when I used to go out into the NHS or talk to government or politicians, and they'd say, well, hospices are lovely, but you don't really help that many people, do you? And they looked at the statistics for the Office of National Statistics, who said 5% of people every year die in an inpatient room in a hospice. So they said hospices help 5% of people who are dying. So they thought we were irrelevant. So what we wanted to do is prove that wasn't the case. And of course, we know the majority of hospice care happens in people's homes or in people's care homes. And that's around 84% at the moment. So when we first did the stats, I was able to stand up and say, you know what? We've helped 206,000 people this year. Isn't that incredible? Aren't we doing an amazing job? And it felt great to be able to say that because, that's a huge number of people. And then so we took a step back and we said, well, how many people are we not helping? So, you looked at the graph before, Patricia showed you some of the stats, and actually across the hospice movement, about 75% of the people we're looking after have cancer, because that's where we came from. That's the origin of the hospice movement, that we started looking at making death and dying better in those final weeks for people who had cancer, whose treatment had stopped. But when we looked more broadly at some of the other conditions like heart failure, renal failure, COPD, neurological conditions, even dementia, it was clear that those people still needed palliative care and in many cases were missing out. So we did a big study and it showed us that around 108,000 people in that particular year, in 2017, could have benefited from hospice care, but were not able to access it. And some of that was down to funding. And some of it was to do with some of the barriers that Patricia talked about as well. So feeling that if I'm in the LGBT community or some of the faith groups, that maybe hospice care isn't for me. And some people came forward in a CQC report and said actually they felt discriminated against by hospice care, that it really wasn't set up for them, it wasn't designed for them, it didn't work for their faith or their family or the way that their lives worked. And so we decided to do a lot more work to address that. So I stood up in year 2 at Hospice UK Conference and said, brilliant news everyone, we've helped 212,000 people this year, that's a 6% rise, we've done amazingly, well done everybody, and it felt great to be able to do that. But the number of people that we didn't help that year had gone up to 118,000. So what's going on there? Well, it's the baby boomers, of course, so we had a massive growth in people being born after the war, which means quite literally more people are dying now. And on top of that, of course, we all know that dying is getting more complex. It's going on over a longer period of time. People are ill with multiple conditions at the same time. And so there's a lot more work that we need to do with every single patient. But on top of that, we were helping more people. So, okay, it was still very good news. I was standing up. And I also found out that year that hospices had helped 46,000 families with bereavement support, which is a massive good news story. We kind of hidden that. We hadn't really talked about the work we do on bereavement, but that's a massive story if we think about the impact. And when I added up the top 3 bereavement charities in the UK, the ones that we all think of, they hadn't helped as many people as hospices had. So we hadn't even told that story as well. But then I came to year 3 and I looked at the stats and we'd helped 206,000 people and I thought, oh, what's going on? It's going down. And it's certainly not increasing year on year. And then I looked at the funding, and the funding had gone up a little bit to hospices, but the costs, even before the NHS pay rises and the potential pensions increase and everything that we've seen this year, the costs for hospices have risen by 5%. And a lot of that is due to living wage and increasing fundraising regulation, GDPR and everything else that we've got to look at. But still, it's getting harder and harder. And then I realised that I go around hospices all the time. I'm in and out of hospices every week. And I see this constant innovation. All the time, hospices are learning and changing and doing things differently. And if you walked into a hospice now that you hadn't been to for 5 years, you wouldn't recognise it. I know that, you know that, because we're constantly changing what we do. But the thing is, we're running to stand still. So what we're doing essentially is being able to broadly help the same number of people, maybe a few more, with constantly increasing costs and reducing money. And I wonder how long we can do that. But I also wonder when we need the big change as well. Because on top of those people that we're not helping, 150,000 people last year died in a hospital ward with frailty. And they had very little palliative care, if any, which means that they probably had no advanced care plan. They had nobody talking to them about how they might die or talking to them about their fears or their spirituality. Nobody talked to them about their family relationships and was there anything that they needed to resolve or sort out before they died. And more than likely, nobody helped their family with any kind of bereavement support. So who looks after those people? Now, it hasn't traditionally been hospice services, and it might sound totally mad for me to stand up here and say, costs are rising, income is under huge threat, and by the way, there's another 150,000 people on top of the 118,000 people we're not helping that we need to look after. But the thing is, I think that morally we do, because the hospice service has always been a disruptor. It's always been innovative, and we've found new ways of doing things. And it comes back to what Nigel Hartley was saying with his triangle. What can we do in partnership with everybody in our community? It doesn't have to be done by us. It can be done by everybody, but we need to make death and dying everybody's business, which means that we need to think differently. So then I started thinking, well, we need to keep on doing the evolving, the evolution, but we also need to think about revolution and doing things differently as well. And it was interesting because one of the sessions at conference that people said they liked the most wasn't even supposed to happen. I was standing there, we'd just finished the AGM bit, and Vicky Browning was supposed to come on the stage from Akivo, and her train was late. So somebody passed a note to me saying, Tracy, can you just fill for about 10 minutes? And I had 900 people sitting there thinking, what am I going to do now? So fortunately, Tony Collins, who's chief exec from the hospice in Harrogate, was sitting on the front row, and I said, Tony, can I just come and interview you? So poor guy sits down, and I'm asking him questions. And I didn't know how long I was going to have to fill. So, in the back of my mind, I'm thinking I can ask him what his favourite planet is or which is the scariest dinosaur. But fortunately, I didn't run out of hospice questions. But the one thing that people said that really struck them was, I said to Tony, what do you think your hospice is going to look like in 10 years? And he said, well, we won't have an inpatient unit. And there was just a gasp across the room. Now, I'm not saying that's right or wrong. We've got about 3,000 hospice beds across the country. And I think that that's broadly about the right number. It might not all be in the right place, but it's broadly about the right number. And I think that we have a moral responsibility as hospices to use those as teaching and learning beds. So every time somebody comes in for complex symptom control, because maybe we couldn't sort out their pain relief, they've got very complex bone cancer, they're very, very frightened, and they come in for 2 weeks, and we try different things and we sort it out, then we've got an obligation to pass on that learning so the next person in a similar case can be looked after more quickly. And let's face it, in an acute setting, that kind of care is unlikely to happen. But in Tony's case, he's in Harrogate, there are lots of care home beds, he wanted to work differently. I asked him the question and he answered it. And that made people think, actually, where is hospice care going and how big is the transformation going to be? And even in our Hospice UK Advisory Council meeting last week, where we have representatives all across the country, we had a big challenge from Imelda, who's the chief exec of the Martletts Hospice down in Brighton. Because she said, Tracy, we've been saying since you arrived that in 10 years' time, hospices are going to look very different. So we're 3.5 years in, so what does that mean? In 6.5 years, hospices are going to look very different? Because I don't see much change. Or are we just going to sit here and say, don't worry, we don't need change for 10 years, we don't need change for 10 years? And I think one of the big things that's frightened me has been the pace of change and the things that I have seen across the hospice movement just in the past 5 months. So one of the big things that I said at conference that shocked everybody was I thought, anecdotally, from conversations that I had with hospices, that 2/3 of hospices last year were running a deficit budget. And there was this sharp intake of breath because you can't run a deficit indefinitely. You'll run out of money. And everyone was quite shocked, and people said, "Oh, I'm not sure that's true, and maybe it'll all come out in the wash, it'll be fine." 5 months on, we've just done a survey of hospices to ask them about their planned budget for next year, and we asked how many of them were planning to run a deficit budget, and it's 82%. And nobody was shocked about that. That's how much change we've had in terms of expectation over the past 5 months. And I think for me, the first big shock was going to close down a hospice. And where's Paul Jones-King? Put your hand up, Paul. Paul, yeah. Paul and I in January were up in Jarrow, and we had to, together with other colleagues, close down St Clair's Hospice. And I think that's probably one of the biggest experiences I've had in my life. It really changed me as a person. And I would say that I was probably grieving for a good week after that. It was like somebody had died. And the really sad thing was, as we struggled and struggled and struggled with spreadsheets and all kinds of ideas to try and save that hospice from insolvency, I remember we got an email from a member of the public, and she said, "You people, you don't understand. It's not about money. It's about care. It's about the fact that we need this hospice service." And of course that was true. But the thing is, if you're in the NHS, you get bailed out and you get saved. And actually, as a charity, as a hospice, we're a limited company. So if the money runs out, the money runs out. Legally, we had to stop. And when we realised we had to stop, all the staff had to be made redundant that day, and we had to tell the public that day. And when we looked at the figures, and Paul and I had only very recently become involved, but if we'd been there 6 months ago, we could have saved that hospice. Because actually what was needed in Jarrow was not beds. They had an inpatient unit that had been closed for months, and actually utilisation was really low, and it was only an inpatient unit hospice. They didn't do hospice at home. But the need was for hospice at home. In Jarrow, they have more care home beds than they know what to do with. So getting any kind of continuing healthcare funding to help shore up the business plan wasn't going to work. There was massive competition for it. It's one of the things that we looked at. But the commissioners, the CCG, the trust all knew that what was needed was a service at home, a hospice at home service. And had we been able to transform the hospice and start doing that and move to that service even 6 months earlier, we'd have saved that hospice. And everyone was desperate to help, but the money had run out. And it really brought it home to me that we can't sit here and wait for St Clair's to happen all around the country. We've got to look at ourselves. We've got to make sure our services fit and they're what the community needs, but that they're also sustainable. And we've also got to talk about what we do. So a few weeks ago, I was on the radio, BBC Radio, Shropshire, because Telford Hospice had suddenly lost £250,000 from their grant from Telford CCG overnight, just been cut. And the chief exec was there from the funders, and he was sort of explaining. He said, charities have had it good for a long time, he said, but it's discretionary funding, and we've got to focus on the NHS, and we've got to focus on A&E, and that's where the public want us to put our money. And so it's been really nice to give these donations to these charities for a long time, but we've had to cut off our donations to charities. So I said, so 7 hospices are going to have to cut 2 beds now from their inpatient unit, which means those people are going to end up in your acute trust, which means that instead of paying 30% of their care, you're now paying 100% of their care. So how does that work economically for you? And you're going to have people coming out of that in an A&E service that you're saying needs a lot more money, constantly bouncing in and out, whereas if they'd been under hospice care, then they wouldn't have to do that. So you're ending up paying more money. And he said, I don't accept that. I don't accept demand's going to increase on acute services. So he was sitting there thinking that hospice care is a nice added extra, but it's not actually complex healthcare. So that's another thing that we need to do. We don't just need to transform what we do and make sure we're working with the public, but we need to make sure everyone understands what we do. And for that reason, we're slightly changing Hospice Care Week this year. So, as well as going out saying hospices are wonderful and don't be afraid of them and they're happy, joyful places and all of the nice things that we do in the celebration around hospices, we're also going to be talking about very, very specific things about what hospices do, because we've got to get people to realise that this is complex healthcare, population-based healthcare. So an example would be Peter, who had prostate cancer, who had terrible pain from it progressing into his bones, and he went into the hospice for 2 weeks and they sorted out his pain and they rehabilitated him and he went home feeling stronger and happier and had another 18 months at home living with his wife. That's hospice care. These are the sorts of stories that we need to be telling people, because we need to make people realise that if we cut these services, if we cut the funding and we lose the services, these are the sorts of services that are going to be lost. So we need to actually talk about what it takes to actually provide hospice care and what hospice care brings, and the fact that it's not discretionary, because if we're any kind of society, then surely we care about the way that people end their lives just as much as we care about any other stage in life. And broadly, I don't want to see anybody die in unnecessary pain with unnecessary symptoms or unnecessary fear or worries, and we know it's still happening up and down the country. So we know that we need to continue to change and evolve. So what does this big revolution look like? What does the big change look like? Well, that's one of the things that I want to throw open and have a big discussion with you all about today, because it's one of those things that really does depend on the local area. We could have come into Jarrow and we could have put all sorts of new things in place. We could have worked with care homes. We could have looked at more long-term conditions and different funding streams, but it wouldn't have worked for St Clair's. So we need to look at each area differently. And one of the things that I would suggest is working more closely with care homes, because if we look at the way people are dying, and we hear this all the time, people going to a care home now are probably a year to 18 months away from end of life. And when we look at ourselves as hospices, that's broadly the length of time that we would like to engage with people. So what does that mean in terms of death and dying? And what does it mean if we want to look after people with frailty? And what does it mean if we want to do more with dementia? So how would we work more closely with care homes? And also accepting the fact that, and I don't know the situation here, there might be an issue with the number of care home beds. So where do we want to stand with domiciliary care as well? How do we want to work with domiciliary care? How do we want to improve that? Do people want to stay in their own homes longer? One of the things that really surprised me about the PopNat data was the number of people over the age of 65 and 85 who live alone. So we always blindly assume that people will be looked after by their spouse. But in actual fact, if the majority of people are living alone but they still want to remain at home and they still want their independence, what is it that we need to do, working with domiciliary care and working with social care, to keep them at home and to look after their symptoms and make sure they understand what's going to happen to them and look at their advanced care planning? So we need to think about that as well. One of the other things that I've been thinking about a lot is about place of care. So are we expecting too much for people, whatever their need, to come to the hospice? And we know that a hospice is a barrier, because one of the things it makes you do is confront your own mortality. So as much as we can say to people, hospices aren't dingy, when you go in everyone will be smiling and they're lovely places, and they are, I've been to enough of them to know, the first time you go to a hospice when you know that you're terminally ill is the day that you confront the fact that you are going to die, and that is absolutely massive for people. And I think there's also that barrier as well, that sometimes people worry about the fact that there are people in there dying and they need to be quiet and it needs to be a peaceful place, and there are all of those sorts of worries. So when we talk about daycare, and are we attracting enough people to our daycare services, should we be running them from the hospice? Or should we be running them in communities and in places where people actually are? And is it quite difficult sometimes for people to be able to get to our hospice buildings? And how far are they having to travel? And where are those people coming from? And are we attracting people from diverse communities? And one of the things that I've been really inspired by is a charity up in Scotland called Chest, Heart and Stroke Scotland. And what they've started to do is run big community hubs out of shops on the high street. So, you know the old Blockbuster video stores, those slightly bigger stores on the high street that many of us see, and they're empty and nobody really knows what to do with them. Well, they went and they took a lease on one and they managed to negotiate it down because it was a bit of an eyesore and it was empty, and they said, we want to do something good for the community. And they put in some retail, they put in a coffee shop right at the front to draw people in, but they've also got a community room in there that they use for their daycare services. They also rent it out to Peppercorn Rent for other charities in the area to come and use for their community services as well. And then I started thinking, you know what, we could do that. We could do our daycare. We could have a room where we have doctor's appointments and outpatient services. We could potentially do chemotherapy for people if we wanted to, have people sit in a nice environment, but their other halves or their carers can go out and do their shopping and be looked after on the high street. There's all sorts of things that we could do out in the community that we're currently doing in the hospice building, but actually we could be then part of those other smaller communities and have much more of a presence. And what would that do for our fundraising? And we've been talking about that not just for adult hospices, but also for children's hospices, and looking at this idea of day respite as well. Because we know that it's difficult for carers, but providing that respite in those blocks of 1 week is difficult and expensive, and they're only going to get access to it for 1 or 2 weeks a year. But what actually happens if people need that small amount of respite? Because you know what, they just want to take their other kids out for the afternoon, or they just need to get on the high street and do some shopping, or they want to have their hair done, or whatever it might be that they need to do. And that's not just for kids, by the way, that's also for carers of adults as well. So could we be providing those services? And if we did, what would that mean for our fundraising? And what would that mean for our presence? And will people know much more about what we're about? And even if we can't invest in that, and by the way, Chest Heart and Stroke Scotland in 18 months have opened 12 of these, so they've been phenomenally successful across Scotland. And that model, we showed it at our retail conference, so if anybody wants to ask me about it afterwards, I can put you in touch, because they're really, really keen for people to go up and see what they've done. But even if we don't want to make that big an investment, we could go to community centres. We can figure out where people are. You know, if we want to get to men, for example, does our local gardener centre have a room? Sometimes they have rooms where they run training and that kind of thing. Tesco's and other supermarkets often have rooms at the back where we could be running services. It's trying to get out. And one of the most popular things I've seen is St Giles Hospice in Staffordshire, and they have this great orange branding now. And they will often park themselves at the front of Tesco, you know, where you walk in, and there's often a bit of space, and they've got their umbrella. And it's just if anybody wants to talk about death, dying, or grief. And often people will just come up and say, oh, what are you all about then? Didn't expect to see this at Tesco. But then they start having a conversation, and then they can be referred, and then they can say, well, you know what, we've got a death cafe going on, and you can come and talk about whatever you want to talk about, and this is the day, and don't worry. And they've made that interaction, and they've spoken to people, and they've got out to where people are. So the transformation doesn't have to be as big and brutal as Tony sat there and said and shocked everybody about in 10 years' time will we have an inpatient unit. Transformation can be as small as saying, you know what, we know that we've got this community on the edge of our patch and we never have anybody ever coming to us from that patch. What would happen if for 4 weeks we pitched ourselves in the Tesco there on a Thursday morning with a couple of volunteers and just started talking to people and see what might happen? What's the worst that could happen? That can still be transformation.